Hi, good evening. My name is Suzanne Tan, and I'll be doing my lung video examination. So first, I would like to ask my patient, would it be okay with you that we're going to video this examination?
Yes.
Okay. So of course, first I would wash my hands, and then of course introduce my self to the patient. Hi, my name is Suzanne. I'll be your student nurse practitioner today, who's going to be doing lung examination. So of course, with every examination, we start first with inspection. So we would inspect the chest wall of the patient, assess for any deformities, and also we'll be assessing for the AP diameter of the lung. So usually the ratio should be at least about 1:2. So posteriorly checking using your hands, and then laterally on the sides, it should be half, so 1:2 ratio. So usually if it's equal, it would mean that there would be a barial chest. So that would be signs of like lung conditions such as COPD. After that, also you will be checking for respiratory efforts and movements. Check for how the patient is breathing. Is he using any accessory muscles, or there's any type of retractions, diaphragmatic breathing. Also, of course, you have to do it also posteriorly and anteriorly. Also expect for, just like when you're doing your peripheral exam, clubbing of the nails, any, color on the fingers and the lips might also be sign of any lung conditions. So, like for cyanosis on the nail beds and everything else. So next is we'll be doing palpation. So when we do palpation, first we're gonna do check for respiratory excursion. So we'll be doing it anteriorly and posteriorly. So I would do it first posteriorly. Okay. So locating the 10th rib of the patient and pushing medially. Then I would instruct the patient to, can you inhale deeply and hold it? So you should feel that your thumb, as right there, should expand to the side, and it should be equal. So that respiratory excursion is normal. So you would do it anteriorly. Can you turn? I'm sorry, it's a little difficult for this examination. So locating as well the 10th rib of the patient, pushing the skin a little bit medially, and then instruct the patient to take a deep breath. So you would see that my thumb would expand. So that would be, it means that it's normal. So after checking for respiratory excursion, we would be checking for tactile femometer. So using this side of your hand, you would do it anteriorly and posteriorly. So you would ask the patient to say 99.
99. 99. 99. 99. 99. 99. 99. 99.
Okay, and also you should be able to hear it, like there's a resonant sound. And then on the back,
99. 99.
so that would be for tactile femosis. Next would be for costochondrial tenderness. So usually when you also palpate the anterior aspect of the chest, especially on the upper and middle side of the chest, the patient would feel that it's painful or it's tender for the patient. So that would mean that the patient is positive for costochondrial tenderness. So after that, after palpation, we would be doing percussion. So to percuss, of course, we will be doing it as well anteriorly and posteriorly. So using the, first we're gonna do the anterior side. So using your middle finger, and then using your non-dominant hand, you would, percuss. So usually we would start here, and you should hear a resonant sound. You can also ask the patient to lift up his hand to the side or up. Okay, and also posteriorly, you would do the same thing. So of course, when it's bony, you're gonna hear dull sounds, but so areas of the lung should be resonant. So that would be checking for doing the percussion. And after that, we'll be checking for diaphragmatic excursion bilaterally. So you would, so both sides, so while the patient is facing backwards to you, so what you would do is you would be percussing. So try to percuss where you would hear the last resonant sound. It means that it's all lung fields, so where the lungs would end. So right there, and then you would make a mark and also doing it on the other side. And then you would ask the patient to inhale and hold it. Okay, checking, make sure it's right there, right there. And then you would, sorry, you would instruct your patient to exhale and hold it. Sorry, okay. So using a pen mark, you would mark it. So right there, then exhale. I'm sorry. Exhale. So right there, right there. So also you would do it on the other side, and it should measure about 3 to 5 centimeters apart, so that it's normal. For some athletic patients, it might be more than 5. Some would be 6 or 7, but that's how you would measure diaphragmatic excursion. And then next one is, of course, you would auscultate the lungs. So using your stethoscope, you would be auscultating, of course, on both sides, using your diaphragm, and you would instruct the patient to, every time you feel the stethoscope, take a deep breath. Okay. Turn right here so the camera can see you. If you can lift up your hands to the side. Okay, and then also posteriorly, you can turn back. Take deep breaths. Take deep breaths.
Then malipong na ko dahil.
Here's your flash briefing from Reuters TV. From Reuters TV, here are the top stories.
So that would be auscultation. So there's also, I'm
Alexa,
sorry,
stop.
I'm sorry about that. There's going to be also additional tests where you can test for bronchophony, where you would auscultate the lungs using your stethoscope. You would ask the patient to say 99, and you should not be able to hear it through your stethoscope. If you can, then it means that there's areas of consolidation. There's also egophony, where you can tell the patient using your stethoscope and then ask the patient to say E, and then you should not be able to, if you can hear on your stethoscope that you would say ah, then that would be some significance that there's also some consolidation. So while hearing for lung sounds, you should not be able to hear any crackles, fine and coarse crackles, rhonchi or stridor. When crackles, like it's like your hair, fine crackles like this, when you like strands of your hair. Coarse crackles would be like a Velcro strap, trying to like you're pulling it out. Rhonchi, it's like snoring. And then of course wheezing. I should know wheezing, I have asthma. And also stridor, like there's like a blockage sound that you can hear when you auscultate. Thank you, and that ends my lung examination.